critical care and kept our contacts up to date for years. We meet about 4 times a year provincially, and then regionally we meet at least monthly. So when we had to pull this all together and do it virtually, the meetings, people already knew each other and there was a lot of trust, which helped. And so we did a lot of planning together so that even though our sites, the rural sites and the more urban sites are quite different, there's been so much cooperation and sharing that it's been unbelievable. Also, nationally, the Critical Care Network is a Google group where we link in together nationally so that the sharing continues to go across the country. I mean, for us, it was really important to figure out we have a low capacity of critical care beds per capita in British Columbia. When I do planning, I look at 70% occupancy for a good ICU to give you that buffer for the emergencies that are unexpected. And most of our ICUs run over 100% capacity, as do probably a lot of you through the country. So we had to figure out how to expand the capacity, which did lead to looking at other areas in the hospital, and also the concern which many of you face is not having enough negative air rooms. So we went down, canceled a lot of surgeries, and then took over a lot of the recovery room, cardiac areas, at which a lot of people have done. So that's all to say that everybody's doing the best they can, but it's not ideal when you don't have single rooms and you don't have negative air and you need it right away. But we've been lucky. We have a lot of, and the other thing that we did, and I'm sure most provinces done, is right from the get-go, we have a dashboard. We are linked into what the status is real time so that we know if a site is getting busier or not, and we'll be able to track that when we start letting things up. We did other creative things like take 4-bed rooms in ICU and redo the venting so that they become a pod with team nursing, which I know lots of people have done across the country. So maybe I'll stop there and
all right, well, that's great. Thank you very much, Miriam. And it's kind of nice to get that perspective from the West Coast and the challenge that you're facing there. I'm going to kind of start to walk across the country a little bit and maybe enter into the province of Alberta. And John, maybe you could address the same question for dealing with that surge capacity.
Sure. Lots of similarities with what Miriam discussed. Obviously, the first approach was led by the operational teams, trying to create capacity within existing spaces. Alberta has about 8,500 acute beds, and by mid-April, they'd freed up about 1,500 spaces. That was accomplished through, again, elective surgeries being canceled. The seniors team put out an expression of interest to the kind of lodge supportive living capacity in the province, and I think there was another 1,000 beds that was created through that process. We're also aware that there's been some unintended consequences of people not going to emergency departments, which again has reduced admissions. So we were reacting early days to some fairly, the original modeling was predicting kind of over 800 beds required. So the initial kind of planning was able to capture close to that. In addition to the spaces that were freed up, there was an estimated about 750 spaces that we thought we could utilize through existing areas in the hospital. The obvious ones being similar type spaces, day surgery, recovery areas, ORs. We've also expanded that to look beyond the obvious ones, looking at rehab departments, outpatient clinics, meeting rooms, even cafeteria spaces. So kind of no area was left out of consideration. The planning teams have been working closely with the operational leadership to kind of provide some guidance and mapping out kind of the utilization and how effective and some of the numbers we could achieve utilizing these alternate spaces. We've worked closely with some of our other municipalities, emergency services groups in planning and scoping out alternate spaces outside of the hospitals. We haven't had to move too quickly on that, thankfully, because the newer modeling is projecting that we should be, comfort is a different term these days, but we should be in reasonably good shape. We have set up a large field house at the University of Edmonton that started out as an assessment center, but potentially can transition to an alternate care space. We have implemented one field hospital, and that's in Calgary at the Peter Lougheed Center. That was graciously donated. The structure itself was graciously donated by Sprung Structures. It's a company based out of Calgary. There's a similar facility going up in Burlington, Ontario with the same group. It will provide an additional approximately 70 beds of capacity. So again, our teams were involved in helping find the location and the implementation of that. AHS has a couple of MASH tents that have yet to be implemented, much smaller capacity, of course. The other thing that we've done, AHS through various sources have received lots of unsolicited offers for tents, trailers, pre-manufactured solutions for spaces, pre-manufactured items to help assessment centers. So we've been collecting all of that information and sharing that with our zone operation centers and our emergency center from the province. So trying to keep the operational folks aware of what the opportunities and potential is if we continue to have to kind of think outside of the hospital spaces.
Yeah, that's wonderful. Interesting to hear certainly the challenges and the addressing the challenges, but now we've got BC and Alberta kind of under our hat. Let's move into Ontario, where perhaps the COVID outbreak's been a little bit hotter. And Mike, maybe you can address a little bit about temporary facilities and dealing with surge capacity.
Yeah, thanks, Gordon. Certainly in our preparation for surge capacity, one of the distinctions we made was the surge of potential for critical care patients. Being having a critical care hospital in downtown Toronto as well. We had the opportunity that was quite fortunate that we had a brand new patient care tower with 100 new beds, including 33 new critical care beds. That was about 95% complete when the outbreak hit. And it was amazing how our contractor group came together to actually push to finish that tower when we got occupancy. And so that gave us a great resource for dealing with any surge that would come about. And in part of that was the separation of patients that were confirmed COVID-19 positive versus persons under investigation versus confirmed COVID-19 negative, and the ability to do that separation. And the other piece being to prioritize what patients went in what rooms. Being having 130-year-old facilities, we were then able to prioritize where do we have single patient rooms for best isolation, where can we actually control the airflow within those rooms, where do we have spaces that are more like cubicles or have dividers and physical separations, if not complete separation, and where are we working in a critical care environment that's just a big, large room with patients in the mixed area. And so we were able to prioritize what patients went where as part of that piece. As was mentioned, one of the surprising differences between the COVID-19 outbreak and SARS has been, when SARS patients were confirmed positive, it was almost an automatic admission to the hospital. Whereas with the COVID-19 outbreak, you were not necessarily admitted to the hospital, but isolated very frequently at home. One of the challenges in downtown Toronto has been the homeless population as well, and where we have persons under investigation or confirmed positive and they have no home to go back to isolate to. And working very closely with the shelters and the city on the challenges that creates, obviously, and ensuring that some of the shelters had some real challenges from controlling outbreaks as well. And so understanding what the strategy is for how to isolate patients who don't have a fixed address has been an interesting challenge as well.
Yeah, I'm sure of that. And we've had some big news items showing up as far as the surge load is concerned in the province of Quebec as well. So I'm going to throw it over to Pierre-Marc and maybe get him to share some of his experience in Quebec and in Montreal particularly.
Yes, thank you, Gordon. Well, I think the approach that we use is very similar to what Michael has just described. We had one of the principles that we tried to put in application since the beginning of the outbreak was to separate different hospitals into hot zones and cold zones. So at first it was quite easy since the number of cases was quite low, but as the situation evolved and as we kept getting more and more patients, the zones or the hot zones that we had determined got quickly filled up. So we had a decision, we designated some of our hospitals to be clean hospitals, so we could use these hospitals for patients that were not infected to limit the risk of contamination. And of course, we also used the outside of our hospitals to build some temporary facilities. For example, on 3 of our hospitals, we have built outside tents for drive-through or walk-in testing. So this was done pretty quickly. We had a lot of help from local suppliers and construction workers. Also, one problem that we faced in some of our whole hospital, we have a trauma center, a level 1 trauma center in Montreal, which is quite old. So we had built outside the trauma center another tent to be able to handle 2 patients at a time. So when we get trauma, we can use the outside tent for these patients. And also in the clean hospital that we designated, we also built a medical ward outside to treat the suspected COVID patients to make sure that we don't get them inside the hospital. And if they needed ICU care, then we would transfer them over to the ICU designated facilities. And again, like my colleagues had mentioned, as the situation evolved, we were missing some negative pressure rooms. So we did a lot conversion, over 150 rooms overall that we converted to negative pressure. And the situation continues to evolve very quickly. So every day we have meetings with the clinical leaders, also everywhere in the province, to make sure that our capacity is continually adapting to the current situation.
So thank you, Pierre-Marc. And both Pierre-Marc and Miriam had mentioned the challenges associated with the capacity or the availability of airborne infectious isolation rooms. And Nick, I'm sure you probably get calls every day on challenges in that area. So what are you seeing relative to that increased capacity of the AIRs?
Certainly, that's, the literature supports that, an intubation is a procedure that goes along with treating COVID and the use of ventilators. And so, and also that it is kind of, seems to be seen as the most kind of dangerous procedure for the healthcare workers and staff. And so the conditions that are set up in an AIR are where you want to do this type of procedure, where you will have the potential or almost, I guess, certainty of generating a lot of aerosols. And, kind of hear constantly that there aren't enough of these type of rooms around. And, the newer hospitals, are probably better equipped, but a lot of the older hospitals have even less of them. But, on top of that is kind of hearing that they really need more and more rooms like that. And in critical care settings, the potential that you really don't want to be moving patients room to room to do intubation. So, should we have more of those types of spaces than we currently do.
An interesting comment that's come in through the chat room is identifying that perhaps even some of the older facilities that still have the operable windows in them maybe are more easily converted in that you can bring in some mobile equipment and vent it out through a window than perhaps a building with sealed systems. And I don't know about your experience in that area, Nick.
Yeah, I mean, there's a bit of guidance around temporary, different ways you can set up temporary AAR type rooms, and using portable units. We've, another kind of related issue there is that the request to use operating rooms and how to operate on infectious patients, and so essentially trying to turn your operating room into an isolation room type environment. And there are some good provisions in CSA about how to set up an infectious operating room. So we've seen a number of hospitals build vestibules, build negative pressure units to ventilate those vestibules, and to keep the OR in a positive state, and have the negative pressure in the vestibule, and even some with the idea that you would do the intubation in the vestibule, and then move the patient to the operating room. So certainly a lot of ingenuity has been going into various solutions, some quite elegant, and some with the use of a fair bit of duct tape on temporary measures to put these provisions in place.
I'm absolutely sure. An interesting question through the Q&A box, actually directed for you, Pierre-Marc, relative to how did you actually go about converting over 150 rooms to airborne isolation so quickly?
We're talking about over 150 rooms spread over 5 hospitals. So I can confirm that sometimes in old hospitals, it's easier. Like we just said, you can just have a HEPA filter, negative pressure machine, take out the window, put the machine. So that was one way that we created a lot of negative pressure rooms. Another thing that we did is exactly what Nick just mentioned for ORs. We built a little room in front of the OR with negative pressure to keep the positive pressure in the OR. And also in the newer buildings, we had the chance to have some flexible ventilation system that allowed us to quickly make some changes to the air volumes that were being thrown in and taken out of some rooms. So it's a mix of everything that we use to convert all those rooms.
Thank you. When you think about this sort of heavy load of patients that are all coming into the healthcare facilities, and all of a sudden we have this one type of illness that we're trying to deal with that has some very specialized equipment, all of the PPE challenges we've heard about across the country and access to ventilators and so on. Curious, I know this is kind of in your wheelhouse, Scott. How are we getting all of the right kind of equipment to deal with this onslaught of patients that are all in the same boat?
Thanks, Gord. It's a good question. I mean, obviously, one of the things that I don't think anybody has really anticipated as has been the ability of the supply chain to supply things. And everybody asking for the same thing at the same time has put a huge pressure on the suppliers. So where AHS has been lucky to have some success is that because we are a large organization, we do a lot of bulk purchasing. We've had strategies in place where we've had pandemic stock already in play, where we had already planned for stuff, had things in our warehouses, had been rotating things into the normal supply chain as it was coming up on its expiry dates. There's other strategies that we've been able to do where things that we've learned from H1N1, for example, we don't keep a ventilator stockpile, we have our ventilators included as part of our rolling fleet at our key sites. So we have more PPE at all times than we really need for our system to act as a buffer in there. So that's something that we've been able to do. But it becomes, as COVID goes on and the suppliers are having their ability to manufacture challenged and distribution challenged, what we've seen is that the lead times for parts and supplies has gotten longer and longer. So being able to keep your existing equipment up and running is getting challenging as we have to wait for parts. And that kind of thing. So that's something that has been a bit of an interesting challenge, because as we all know, with publicly funded healthcare systems, there's not a lot of interest in having parts sitting on the shelf. So we typically do a lot of on-demand purchasing for supporting our equipment. But now we're running into situations where we've had to be very creative within our clinical engineering departments to keep our existing equipment up and running and to get additional stuff up and running for the ICU surge spaces.
Yeah, I can certainly appreciate the challenges of dealing with that. And you mentioned, part of that stock coming as a result of preparation around H1N1 and Ebola and so on. And we made a lot of changes to our facilities and the design since those times, but we're still kind of caught short just a little bit on this COVID-19 outbreak. I might throw the ball over into Lynn's corner to maybe talk about where some of the changes have occurred and perhaps where we need to continue on that path of change as a result of some of the lessons learned from COVID-19.
I think they start at the emergency door, because during an outbreak like this, that becomes the main entrance to the hospital. So it becomes, I think, a system optimization and a flow issue where we have to look at how are we getting the non-COVID patients safely into the hospital and into the emergency, because people still fall off of bicycles, people still get hit by cars. They have heart attacks, and we need to get them safely into the system. And then how do we get the COVID or COVID suspected patients in there? And there's a really interesting study that was done back in 2008 called ER1 that looked at that exact issue of how a hospital could respond to a pandemic. And one of the things it found was that you really need more than one entry into your emergency department. You need to be able to separate those flows and then to keep them separated throughout the hospital. And what that's going to have us do is go back to the basics of the master program and the master plan. And when those are being put together, when you're looking at how many beds do you need, how many critical care beds do you need, we're going to have to be looking at, okay, that's how we're going to operate on a normal basis. But what's going to happen when we do have a pandemic? And one of the things about COVID that's very different from SARS is we knew how SARS was being transmitted within a couple of weeks. The science on COVID-19 is still not all that structured. There's a study that came out of New York last week that showed that COVID-19 was throughout an entire hospital because it was being tracked on people's shoes as far as into the pharmacy. So, how did it get there? What does that mean for design for the future? So it becomes that whole process of how our people move through the building, how our supplies move through the building, and how do we separate them? And I think the biggest thing that's come out of COVID-19 in terms of design is how do we solve the horrendous issue of the separation of people from their families. I mean, that's been absolutely heartbreaking. So as designers, how do we create a safe environment for staff to work in, for families to be there? Same thing as intubation. I mean, we can do that in terms of mechanical systems. What can we do in terms of connecting people with their families? And the IT systems that are becoming available may be one of the solutions, but we need to look at it architecturally as well. And one of the things when Nick was talking about the ORs, I mean, he doesn't remember, but 15 years ago, we actually designed one after SARS at Sunnybrook for the birthing facilities there, because it's a big regional tertiary care facility. So one of the birthing ORs has a vestibule, because women will still get, babies will still decide to be born in the middle of one of these. And if the mother is COVID positive, how do you keep that from going throughout the facility? So I think it's that we're going to have to start to look at, as I say, at the master program stage and the master plan stage, is where do people move to in the hospital in all these different scenarios? How do we get them there safely and keep everybody else safe at the same time? So maybe one of our ORs in every major center has to have a vestibule. Maybe one of our trauma rooms needs to have a vestibule or a separation. I don't think we know the answers yet, but I think we're beginning to learn what the questions are.
Yeah, so that's a great point, Lynn. And actually, one of the comments or questions that's come in through the Q&A panel is sort of asking specifically that question. We've taken very quickly. We've had to take spaces and convert them for a purpose for which they were not originally designed. And the question is basically, should we have some sort of a percentage or some ability within our buildings to flex some of those spaces from one purpose to another, which creates some inherent challenges and some risk. But maybe I'll ask you, Miriam, if you would address that a little bit, that flexibility or having spaces that have some degree of flexibility to them.
Right. So I've been the chief clinical planner for the new St. Paul's Hospital from inception, really full time, for 4 years now, and always on the top of my mind, I'm thinking about how do we not waste space, but how can we be flexible? Because moving patients around from one kind of care area to another is very inefficient, and that's when a lot of the balls are dropped. So, the concept of having any room that could potentially be a critical care room, it is expensive, but as we see now, if you have single rooms and you have gases in the rooms and they're big enough, pretty much any room could be a critical care space, which I think with this COVID, I wish our hospital was built. So that flexibility of having the privacy and the ability to take different areas that may be a critical care bed or just a regular bed or a care space for recovery, that concept of how can they be used quickly as different spaces. So plumbing the gases appropriately. I know also in our new plan, we have procedure rooms in outpatient areas, and they will have gases and the proper air exchange. So in my mind, I was thinking if those could be spaces as well. So I think when you're doing planning for the future, because again, we don't know what that next pandemic is going to be, and they're all a little different, but being able to separate flows and have that flexibility so that you can be really nimble and care for folks in a different way.
So, Mike, I might turn that right in your direction. Then I know the Z8000 standard that CSA produces has some very specific spaces and functionalities within there. Are there lessons coming from COVID-19 where flexibility and perhaps multi-use spaces might be a consideration on a go-forward basis?
Certainly, and Miriam's already alluded to the fact that the single patient room standard has really, where it's applied, set us up well to deal with these types of outbreaks, and just in the separation of patients alone, and then the ability to make other changes to those rooms based on the infrastructure, and having rooms that have that flexibility of acuity. So that, as Miriam said, the ability to change an acute care room to a critical care room with ease was an important piece in looking at preparation for where to care for some of the COVID-19 patients, especially if the original projection curves for critical care patients would ever to have come into play. I think one of the other interesting pieces that we've seen from a standard standpoint is the need for having this appropriate space for PPE. You know, again, where you might have a large deployment of PPE donning and doffing areas outside of various patient floors, patient rooms, making sure we have the appropriate spaces allocated within the standard for PPE resources and for putting those on and off is an important space consideration to, again, allow that surge and flexibility.
Thanks for that, Mike. And a question that's coming up actually multiple times between the chat and the Q&A around the ER1 study that you had mentioned, Lynn. Folks are looking for that reference, so I'm just going to throw it out there that we'll make sure we get the reference to Rita and she can get it to everybody who is registered for today's event, so they're able to go and find that study in its detail. If you can follow up on that, Lynn, that would be absolutely fabulous.
No problem. And one of the things that it also recommended was more use of acuity adaptable rooms. So both Miriam and Mike have referenced those, but that's something that we see more in the United States than we do in Canada because they tend to be bigger rooms. So they're more expensive to build in terms of a capital outlay, but in terms of an operational cost, when you don't have to move people to intubate them, when you don't have to move them because they're no longer requiring critical care, but the cost of moving a patient is very expensive, you can start to look at the comparison between those two things, that initial capital cost and that long-term operational cost.
Yeah, Nick, if I can jump in again, Gordon, Nick mentioned earlier about, and so did Pierre-Marc, about the ability to turn rooms into negative pressure and how that conversion's been happening either through punching out a negative air unit or making changes to the system. And I think that's another important area of flexibility whereby our air systems often have, you know, the appropriate controls and dampers on them that you can control the amount of air that's going in and out of a room, and the ability to, in not all cases can you make a room a negative pressure room, and Nick will certainly nod his head when we're making negative pressure rooms. The goal isn't to make it negative pressure so much it is to control, to have inward directional flow, so that the flow of the air is actually moving into the room as opposed to moving out of the room. And we use pressure to monitor that because it's easy to monitor pressure. But certainly having the ability to adjust your supply and exhaust air in the various rooms so that you can create an environment where the air flows inward to the room in these types of infectious outbreaks is an important area of flexibility in the infrastructure as well.
Absolutely great insight, Mike. I don't know if you want to add to that at all, Nick.
Yeah, I think you know, one of the important things to keep in mind in situations like pandemics is that you have a whole bunch of patients with the same issues. So typically an isolation room is kind of a one-off thing. So what we've seen, and there's been it's not a brand new concept, but that of an outbreak control zone. So in the projects we've been working on in BC over the last 12 years, I think we've seen an increase in the number of these outbreak control zones where you take a typical patient unit, nursing unit of a subunit maybe of 16 or 18 or 14, depending on the setup of the hospital, and the requirement is to basically turn that into one giant isolation room. So through the controls on the air system, it has to be an automatic setup, and then create a vestibule on the way in, either in the corridor or often using a room off to the side. And so it's, from that point of view, it's a far more sort of efficient way to deal with a large group of patients that have the same issue. They're not going to catch COVID from each other. And the capabilities on some of the recent projects, like the one Miriam's looking after, are basically half the rooms, half the patient rooms, half the critical care rooms will have this provision.
So, Pierre-Marc, you talked about having a separation of buildings where you had hot zones and perhaps cold zones. Are you seeing any of this separation within a building itself where you've got some isolation control spaces as Nick was just describing?
Well, the way I see it, I think the key is flexibility. So you need to be able to, when you're planning, I think a new building, you need to be able to think about that separation. But of course, you might not need that separation for every time. From my experience, we just designed two very recent hospitals in Montreal. One, I think Nick participated, the CHUM, and there was some planning about the pandemic zone and different medical wards dedicated to outbreaks. But what we realized today is that this was not adapted for a disease like COVID, because having a medical ward is one thing, but these patients, they need to go to radiology, they need to go have some exam inside the hospital. So again, you come back with all the trajectories that you need to be planning, but always keep in mind that you need to keep that flexibility to adapt. So I think it's important to keep that in mind, to have that separation, but it might not be always useful. But I think really the key is to have that flexibility and to be able to adapt to any circumstances.
Great. I think you appreciate that. Adaptability is certainly something that we've seen, although perhaps not planned for. Prior to COVID-19, we've seen our healthcare system as a whole making significant adaptations to try to address the situation. I want to change gears just a little bit. I mean, I saw a recent headline that was showing something to the effect that 4 out of every 5 deaths in Canada were occurring in our long-term care facilities. And I want to explore that a little bit, and whether or not maybe we should be thinking about changes to the way we design long-term care, and perhaps provide the spaces for our seniors at that stage in their life. And I'll ask John, maybe if you chime in on that one a little bit, what's happening from your perspective around long-term care and potential changes in the planning.
Thanks, Gordon. Yeah, I think first of all, acknowledge that the numbers are staggering. Yes, that's a population that's susceptible, but certainly there has to be some learnings out of this that we can implement into future continuing care guidelines. It may be premature to kind of get into specifics because, as Lynn mentioned, the science is still evolving. We also have to acknowledge that throughout the country, we have seniors in facilities that are meeting guidelines that might be 20, 30 years old. So whether this can be an opportunity to maybe replace some of those aging facilities, I guess that's up to the funding agencies. Certainly there's operational opportunities as well, and you can read about it in the newspapers these days. Staff education, the pandemic preparedness. In Alberta, there's been lots of discussion about staff working in multiple facilities. I think Ontario's been able to address that. It's still kind of evolving in Alberta. Visitation issues, again, Lynn alluded to the challenges that we see on the news as well, people talking through windows. So when it comes to design and future opportunities, again, I think there's probably some great studies that can be done. The whole transmission piece, whether we're addressing that properly in our continuing care facilities, again, science I think will have to be vetted a bit further. This may potentially impact kind of the B3, B2 classifications. I think there's a trend to kind of relaxing some of the expectations, and we may see a trend, and probably should see a trend, reverting some of that back to help protect the residents. More specific items, again, I think some of the facilities that have been in the news lately, older facilities where residents are sharing rooms, sharing bathrooms. Obviously, all of the new guidelines would not support that. but whether there's opportunities to strengthen some of that. I know in Alberta, the recommendation is 18 residents or clients per pod or home, or whatever the terminology is in your areas. Again, I think there may be some opportunity to revisit that and see if there's a balance to be had between the operational costs, the facility costs, and optimizing the ability to easily contain residents in smaller groups or cohorts. The patient kind of family resident interface, again, I can speak to my experience visiting my dad. We kind of gather in the room, you walk through the ward, whether there's opportunities to think differently about how those types of interactions can take place. Some facilities have opportunities for gathering found spaces, whether there should be more emphasis put on that to kind of make it as good an experience as possible, but kind of limiting exposure to other people. Again, I think it might be early days to be thinking about this. I don't think I would suggest in the current guidelines there's an inherent flaw in how the facilities are designed, but absolutely there are learnings to be had, and I think there's some opportunity to study, even looking at the types of facilities that have had these staggering numbers, and again, whether that can leverage some movement in terms of replacing them, because time will tell.
Yeah, I think you're absolutely right. I know, Lynn, you had talked about right out of the gates, we started about the human interface and some of the challenges that we see with the loved ones of residents in long-term care facilities that can't visit with them, can't be with them in some of those trying times. And I'm curious about your perspective about potential adjustments in our thought process around long-term care facilities and how to lay those out to help improve that human experience.
Well, I think the first thing I want is more sinks. I know that's not the human experience, but in those 4-bed rooms, I want more sinks so that because a lot of those very old facilities don't have that. But we look at the way we design long-term care facilities as though they're a hospital. And I think the situation that you see in some of the facilities in the Netherlands is something that is much more designed for people to age in place, and we haven't really figured that out all that well in this country. Assisted living facilities are certainly a good direction that way, because they do try and keep people within small apartments, and then they start bringing in more care. But because they're designed as apartments, you have to start stripping out everything that makes them comfortable for people. So I think we have to really step back and think about how would we as individuals, because we are the next generation that will be moving into these facilities. So what is it that we will want? And I think one of the things is the connectivity that you were mentioning earlier, and that is very different for this generation. Although I look at my 92-year-old mother-in-law who's on the internet every day and in connection with family members, and I think that's something that we can start to look at very differently, because a lot of those older facilities don't have Wi-Fi, they don't have internet connections for people, and giving somebody a small iPad is probably not the best thing to do. It can get very complicated. So we need to look at the kinds of connectivity that we can provide, and that can be physical, it can also be virtual. But I would love to see the facilities designed so that, as John was saying, we don't have 18 or 20 people in a pod. We have smaller pods. We have more connectivity between staff and patients and not even treating them as patients so much. So I think there's a lot that we can do there. And I think, as I said, there's some very good examples from Europe that are very different from the way it's designed here.
So, Mike, I know that there were some significant changes in the 2018 edition of Z8000 relative to long-term care. What are you seeing there that maybe we need to even take a little bit further going forward with the lessons we're learning during the COVID outbreak?
Yeah, I think, you know, and Lynn captured a lot of that there. I think where we sort of had a position on long-term care that we wanted to be as, you know, we wanted to separate the differences between long-term care and acute care. And some of those were some of the more stringent, requirements, such as, you know, how the single patient room was applied, how hand washing sinks were applied, and so forth. And I think it's something we need to revisit more closely now, that, you know, outbreaks and infection control isn't more of an issue in an acute care hospital than it is in a long-term care facility. In fact, it may even be the flip side of that. And so taking the learnings from how COVID-19 has affected our long-term care facilities and what we can do that uniquely looks at those types of facilities and the type of socialization that happens in those, the type of care that happens in those, but at the same time applying the right infection control principles.
Great, thank you, Mike. I feel like I've been ignoring Scott a little bit over the last little bit, so I'm going to bring him back in here for a final thought relative to perhaps one of the big lessons learned out of the COVID outbreak and what we can all take forward from your perspective.
So, I mean, one of the big perspectives that I can say is for us from the biomedical world, ventilators have been the talk. It's been worldwide talk about ventilators, and certainly, you know, motor vehicle manufacturing switching to producing ventilators and that kind of stuff. It's been very interesting to see what kind of novel innovations we're going to get out of this. But from our experience, from what we've seen, just because patients are in the hospital doesn't mean they're in the ICU, and just because they're in the ICU doesn't mean they're on a ventilator with COVID. That's been our experience. So we have to, you know, when we're looking at the numbers today across Alberta Health Services, you know, the majority of our patients that are on ventilators are not COVID-19 patients. So we still need to have the ability to take care of those patients and have capacity for, I think it was Lynn or one of the other ladies that I mentioned, you know, motor vehicle accidents happen, heart attacks happen. We still need to take care of labor and delivery, all of those types of things. So one of the things that we've been struggling with is the capacity of your medical air system and your oxygen systems. What happens when, you know, you extend all this gases and piping out there, but you're not looking at the flows that you're going to get when you double your ventilator usage or triple your ventilator usage, or you add in high heated output flow oxygen. So those kinds of things, it's not just about having the availability of the piping to the rooms, it's the capacity within the system. And what happens from a pandemic response when you need to have more oxygen deliveries? Do you have the ability to park a trailer on site and have increased oxygen fed into your hospital to meet your demands when you've got that many more ventilators and oxygen consuming devices running? So that's something that's been a unique challenge that we've never anticipated before, because, you know, even though we may have a lot of ventilators in the system, they're not all on patients at the same time. The same thing goes for infusion pumps and our physiological monitors. They're not typically all in at the same time, but when you have a pandemic situation, you've got a lot of equipment being used at the same time. So it becomes a challenge on your ability to supply power, your ability to have your IT infrastructure network, if you need to network those devices, if you're looking at electronic charting, if you're looking at electronic surveillance, as we start looking towards some of those things that are becoming trends within critical care. Those are things that we need to be aware of is, you know, what's your normal usage and what is your surge capacity usage?
That's great. Thank you for those thoughts, Scott. And I wish I wish we had about another 7 hours with you folks. There's a lot of great insight that we've been able to pull over the last little while, and the hour has just absolutely disappeared way faster than I had hoped it might. I want to thank each and every one of the panelists for taking the time to be with us today to discuss the challenges that you've faced and how you've overcome all of those. And certainly for everybody listening in, I want to thank you for all of the very important work that you folks are doing in supporting our acute care and long-term care facilities right across the country. It certainly has been difficult times, and we're not out of the woods just yet. But we're going to get through all of this, and my hope is that we'll all be able to take some great lessons away, and that when the next wave hits, we'll be better prepared, or when the next infectious disease hits us, we'll be that much better prepared for that when it comes. So Rita, I'm going to turn it back over to you for the last word, where we're right at the very top of the hour, and to take us to the very end of the webinar.
Great, thanks. Thanks so much, Gordon. And yes, thank you for a fabulous panel discussion today. We are going to be, when you close out of the session, providing a survey, and we would like to move forward with more webinar topics in future. And you will be, you're welcome also to get in touch with me, and we'd love to hear from you in terms of feedback. As mentioned, this was our first virtual webinar, and I'm sure there will be many more in future. So thank you again, and have a great weekend. Bye-bye.